Good afternoon, everyone. My name is Ann Wong with the Illinois Chapter American Academy of Pediatrics, and I thank you for joining us for today's webinar on measles. Today we are joined by Dr. Anita Chandra Puri from the Northwestern Medical Group. Before we begin, I would just like to go over a few housekeeping items. First, this is our webinar planning group, and I would just like to say that nobody on the planning group, presenter, content reviewers, or CME application reviewers had any disclosures. Today, you will be receiving 1 credit of CME, and nurse practitioners can submit certificates of attendance to their accrediting board for credit for participation in the live webinars, and the funding for this webinar was provided by the Chicago Department of Public Health. Some general information: all participant phone lines are muted. This webinar is being recorded. Everyone will receive a copy of the PowerPoint slides in PDF form, a link to complete the evaluation, and a link to the recording of the webinar by the end of business day. If you have any questions for Dr. Chandra during the presentation, please enter them into the question box on your control panel for the webinar located on the right-hand side of your screen. Your question will be answered at the end of the presentation. I would now like to introduce Dr. Anita Chandra Puri. Dr. Chandra has been a pediatrician with Northwestern Medical Group in Chicago since 2001. Originally from Ohio, she received her MD from Northwestern University's Feinberg School of Medicine in 1995 and completed her residency at Northwestern's Children's Memorial Hospital. She maintains a strong affiliation with the medical school as an instructor in clinical pediatrics at Northwestern University. As faculty tutor for the Education-Centered Medical Home, she teaches students about primary care medicine and has served on the medical school's curriculum committee. Over the years, she has worked in various capacities with the American Academy of Pediatrics Illinois chapter, including the Committee on Infectious Diseases and Immunizations. Dr. Chandra is a champion of childhood immunizations and is a media spokesperson for the AAP and Northwestern Medicine. Outside of work, she serves on the boards of EverThrive Illinois and the Neighborhood Parents Network. She is married with 4 teenage sons and enjoys reading, dance, and travel. Please join me in welcoming Dr. Anita Chandra Puri. All right, I'm going to switch it over to you right now, Dr. Chandra. So give me 1 second. Okay.
Okay, hi everybody. Thank you so much for joining us during your lunch hour. I want to make sure that we can get your slides to show up here properly. It looks to me like it's still loading, so if you want to give me just a moment. As Ann mentioned, I'm a pediatrician with Northwestern Medicine, so in that capacity, I'm a primary care pediatrician, but I am particularly interested in childhood immunizations and making sure that we protect as many people from some of these vaccine-preventable illnesses as we can. I'm not quite sure what is happening here. I still have here we go. Let's see if this is helping. Okay. Can you hear me, everybody?
Yes, we can hear you.
Okay. For some reason, it's not. It's not showing you the full screen yet, so I'm trying to figure out why. There we go. Let's see if this is working. So sorry. The technology part of this is a little difficult. Okay, so let's see if this is working. 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 Okay, so let's
maybe try pushing the play button right up there in the top right-hand corner.
Sorry, everybody.
That's okay. If you want, Dr. Chandra, I can go ahead and advance the slides.
Yeah, why don't you drop the slides?
Okay. And then you can just tell me like when to advance and everything.
Fine.
Let's go ahead and do that. Okay. I think we're all set on my end. So do you want me to go ahead and head to the disclosures slide?
So this is obviously the measles presentation. It's an old disease with a new resurgence, which all of you are, of course, aware of. I'm hoping, being practitioners here in the state of Illinois. I have no relevant financial relationships with the manufacturer of this vaccine or with anything to do with the CME activity specifically. And I certainly am not going to discuss anything that's unapproved or investigative only. Next. The goal of this presentation is to review the recent epidemiology of measles in the United States and Illinois, to discuss the clinical presentation, because I'm assuming the majority of you have never seen the measles, and how we diagnose the measles. And then we want to review the role of public health in the measles outbreaks and how we can control this from spreading further. We're going to specifically focus on vaccinations. Next. In 2000, the measles virus was essentially declared eliminated in the United States, meaning there were no endemic cases of measles in the United States. If we look at the number of cases reported by year, there were a low number of cases in the early 2010, 11, 12 time period, and these were all imported cases from other countries where measles still is plentiful and endemic. In 2014, we had a surge of measles cases, primarily focused in pockets of the United States where there were unvaccinated people, or areas where there were low vaccination rates. Again, originally it started from imported measles, but then spread within those areas. Then there was a lot of activity, a flurry of activity in terms of work against religious exemptions or philosophical exemptions in various states, really pushing education on vaccination. And we were doing a decent job in decreasing the numbers again. But then this year, of course, has been the largest number of cases reported in the United States since 1994. So far, we have 940 cases of the measles reported in the United States. If we look at the states next, with reported measles cases, the darker states, darker blue states are all states that have had measles reporting, including Illinois and our neighboring states, Indiana, Michigan, Missouri, Iowa, and then there are higher numbers of cases on the East Coast and on the West Coast and all the way down through the southern border, including Texas and Florida. Next. If we look at the recent outbreak areas, these are in order of the largest number of cases towards the top. Rockland County, New York, and then New York City, New York comprise the majority of our cases of the measles. The majority of the cases are in children under 18 and in those who did not have measles vaccination. The 535 confirmed cases of measles in Brooklyn and Queens were from September of 2018, and most of these cases involved members of the Orthodox Jewish community. In Washington State, the majority of the cases were in kids under 18, and again, those who did not have the MMR vaccine. And in Oregon, the majority of the cases are again in kids under 18. If you follow the news, there are a significant number of cases in Michigan as well. And then in our state of Illinois, there are so far 8 reported cases of the measles. Next. If we look at who is getting infected, like I mentioned, the majority of our patients who are getting the measles are unvaccinated or whose vaccination status is unknown. During this time period, if we just look in 2019, of the children who are getting the measles, the median age is 6. The largest cluster of cases is really in the 16-month to 16-month to 17-year-old age group. And again, 90% of those who are getting the measles seem to be either unvaccinated or whose vaccination status is unknown. Next. Overall, 9% of our patients who have had the measles have been hospitalized in the United States. Most of the cases, again, were related to outbreaks. 75% were related to outbreaks in New York specifically. The source countries are interesting. There has been an upsurge of measles throughout the world, but particularly large increases in the measles in the countries of Ukraine and the Philippines and Israel and Thailand and Vietnam, in Germany. We're going to look at a map shortly that's going to also show us some other countries across the world. But there have really been an increased number of cases in other countries, increasing the exposure risk to patients who travel there, or again, patients who are unvaccinated. Next. So this kind of highlights what I was saying, that what's contributing to the outbreaks in the United States is an increase in measles globally, international travel to areas of high endemic regions, something we're going to focus on called vaccine hesitancy, and then community pockets of low vaccine coverage. This slide shows you some of the increase in global cases of the measles in the past couple of years. The darker maroon color represents the highest number of cases. And this would include Ukraine, Romania, Italy. There are several cases in Germany, large pockets of cases in Russia, Spain, France. So really places, in Western Europe that we weren't thinking were such a problem are now also problems with the measles, in addition to the cases that we know of in Asia, in like Eastern Asia. Next. This is another representation of the highest incidence per million people of the measles. And you can see Ukraine really is topping our numbers here, but Ukraine, Serbia, Albania, Liberia, Yemen, Montenegro, Greece, Madagascar, Israel, and the Philippines. Next. So the World Health Organization has ranked different threats to global health for this year. Several of these are things that we would think about: air pollution, non-communicable diseases, the global influenza pandemic, fragile settings, antimicrobial resistance, Ebola, weak primary health care, dengue fever, and HIV. But in there is also vaccine hesitancy. So this really means complacency. People who feel that it's inconvenient or have an inconvenience in accessing vaccines, or they lack confidence in vaccines or healthcare providers. These would be key reasons for underlying hesitancy, and we're going to talk about some of this here. So these are some different sort of cases that illustrate the measles outbreak and some of the issues with vaccine hesitancy. In Rockland County, New York, there have been 254 cases to date. Like I mentioned, the outbreak started in September of 2018 when an infected international traveler brought measles into the community. Rockland has already had to declare 2 different states of emergency in the country to try to stop the spread of the disease. And among the cases, the majority of the people were unvaccinated, and the large majority are under 18. If we look at Oakland next, if we look at Oakland County, Michigan, there was an individual who worked as a fundraiser in New York City and then traveled to Michigan mid-March, likely caught the measles from the New York City outbreak. The outbreak in New York City was originally believed to come after an Israeli citizen, from Israel, a citizen from Israel who had come into the Orthodox Jewish community and spread it within the community in New York. And then in Michigan, a traveler from New York came to Michigan and spread it as well. Michigan is one of 17 states that allows parents to opt out of vaccinating their children for religious or philosophical reasons. The statewide average for waiver rates has dropped since the 2014 law, but the rate is still 2.4% of the population still is unvaccinated. Oakland County specifically in Michigan, where the outbreak has taken hold, has a vaccination waiver rate of 4.8%. So that's 2 times the state average. Next. Oops. If we look at measles in Illinois, the first case that we had was unclear exposure, but it was in the Champaign area. And then the other cases in the Champaign area were unvaccinated college students. In DeKalb, additionally, it was an unvaccinated college-age student returning from a mission trip. And then in Cook County, it happened to be a vaccinated adult in their 50s who had traveled to Israel. But as we know, not everybody responds 100% to the vaccine. This unfortunately was one of the people who was still susceptible to the measles who was able to contract the disease. If we look at just the clinical presentation of measles, which, like I mentioned earlier, the majority of you probably have been fortunate to have not seen the measles. The incubation period for the measles is 7 to 14 days after exposure on average, but it can be up to 21 days. The first symptoms of the measles are a fever and the classic 3 C's, cough, coryza, which is a runny nose, and conjunctivitis. 2 to 3 days after the initial symptoms appear, small white spots known as Koplik spots can appear in the mouth. And 3 to 5 days after the initial symptoms appear, a rash consisting of flat red spots will begin to appear on the face and spread to the neck, limbs, and trunk. The person's fever can spike up to higher than 104 during this rash stage, and usually the fever and rash subside after a few days. This picture shows you a little bit of the conjunctivitis, the head cold type of appearance, and the beginning of the rash. These next pictures show you Koplik spots. If you can see on the left picture, the white spots there on the roof of the mouth. A little bit harder to tell on the right picture, but these are the classic Koplik spots, which are small white spots inside the mouth. They usually start 2 to 3 days after the symptoms start. And next. The rash is usually 3 to 5 days after the symptoms start. It begins as red spots that appear at the face or at the hairline. They spread downward to the neck, trunk, arms, legs, and feet. You can have some small red bumps, small raised bumps as well on top of the flat red spots, and then the spots can become joined together as they spread from the head to the rest of the body, giving you the characteristic maculopapular rash of measles. The next slide shows you sort of the truly classic measles rash. And this is another graphic to kind of describe the timeline of infection. You have the exposure period, which then it incubates in the body for 7 to 14 days, up to 21 days. Then you'll have the onset of sort of viral symptoms, which unfortunately are so similar to many other illnesses, with a high fever, a cough, coryza, conjunctivitis, and you have the Koplik spots. Then you may have the rash develop, and the rash spreads caudally. You may still have fevers during that time period. And then the rash will typically last 5 to 6 days and will disappear in the same order that it appeared. Next slide. The complications of the measles are very common, particularly in developing countries where we have many more cases of the measles. But just so you're aware, the different complications which are seen more in the high-risk population, including younger children under 5 and anybody who's immunocompromised. Diarrhea is a significant complication, and in other countries where they can't necessarily keep up with the dehydration, it can be a cause of death. Otitis media or ear infections are common complications and can lead to permanent hearing loss. Pneumonias are a complication. Hospitalization, of course, is a complication, and the more severe complications include encephalitis. 1 in 1,000 cases of the measles will lead to encephalitis. Death is a very unfortunate, terrible complication of measles, of course. 1 to 3 out of 1,000 cases of the measles do result in death. And then a rare but possible complication of the measles is something called subacute sclerosing panencephalitis. It's a fatal degenerative disease of the central nervous system, which doesn't appear until about 7 to 10 years following a measles infection. The characteristic of this disease is behavioral and intellectual deterioration and seizures. This can be seen in 1 out of 1,000 cases of the measles. Next slide. Measles is highly contagious. It infects 9 out of 10 people exposed, and it is spread in airborne infectious droplets. When an infected person breathes, coughs, or sneezes, you can see the plume of infectious droplets in that slide there. And the virus can remain infectious in the air for about 2 hours after an infected person leaves an area. And because this disease is spread so easily, this is why widespread vaccination is critical to preventing disease in large numbers of people. We talk about diagnosing the measles, again, because people have not seen it as frequently. It's something we all want to keep an eye out for. Like I mentioned, of course, some of the initial illness symptoms can mimic other illnesses, including, influenza or adenovirus or other viral infections, but fever, rash, and then the 3 C's. You also want to consider what is the patient's vaccination status and what is their travel history when you are considering measles in your diagnosis. This is a measles testing flow chart, which it's, basically, I think the bottom line of this flow chart, and you can certainly take a look at it in more detail, but if you are concerned, if you have suspicion about the measles, whether it's because it's an unvaccinated person presenting or person who's recently traveled or who fits the clinical picture, you definitely want to contact your health department or the Illinois Department of Public Health immediately for direction on specimen testing. This is going to be something that's critical to, obviously, infection control, and you want to know exactly what tests to perform and how to get the testing to the right location. Next slide. This will be on your PDF file that you'll get, but the Illinois Department of Public Health has numbers listed here, and otherwise you can always go online to look up your local health department contact information, but the key is to contact them immediately. You don't wait till the next day, you contact them immediately and they'll give you further guidance on testing and care. Next, in your office, if you do see somebody that you are suspecting measles as the diagnosis, you want to mask and isolate the patient immediately in a negative pressure room if available. That's really not commonly available in most private offices, but you do your best. If somebody calls into your triage system and there is suspicion of measles, what we typically do is have them masked before they even come into the office. We walk them back directly into a room, or if we're really suspicious, of course, we're going to discuss what to do with them even before they come into the office. Only staff with documented immunity can care for a patient. I would hope that all of your staff has documented immunity anyways, and documented immunity means either 2 documented doses of the MMR vaccine or lab evidence of IgG immunity. You don't want to use the exam room that the patient was in for at least 2 hours after the patient has left the room, and you want to fully disinfect the room. As I mentioned earlier, it is contagious, or the droplets can remain in the air for 2 hours after somebody has sneezed or coughed in that area. And then just to kind of talk about the samples for testing, if you're doing serum testing, you're looking for IgM or IgG, and you're going to be sending that to a commercial lab. If you're doing nasopharyngeal swab testing, you're doing a PCR test basically, and you're sending that to the Illinois Department of Public Health. The timing of what to do really depends upon how long the patient has been ill, because you'll have different results based upon the timing of the illness. Next. The instructions for sending the nasal swab to the Illinois Department of Public Health will be on that website that's there. The key is that you collect a specimen as soon as possible after onset of the rash. You don't use cotton-tipped, wooden shafted, or calcium alginate swabs. And you refrigerate the specimen and ship it in a cold pack. But again, this is not something you'll be able to necessarily remember until you have to do it. So you should always, first line, call the Illinois Department of Public Health for support. The next slide tells you that the specimens have to be received by IDPH as soon as possible, but within 96 hours of collection, and the addresses and phone numbers again are listed there. These next couple of slides give you just some idea of what's going to happen in different phases based upon the type of individual you are working with here. If it's an unvaccinated individual, IgM antibody typically appears within 3 days of the rash. False negatives are possible, not positive, but false negatives are possible if collected less than 72 hours after the rash onset. Typically, the IgM is positive for about 30 days after the acute illness. And if it is negative at less than 72 hours from the rash onset and you still have suspicion, I would repeat the IgM. PCR testing, usually it's present around the time the rash occurs. The PCR will be positive around the time the rash occurs. It declines within 7 to 10 days, and you can have possible false negatives if collected after the rash onset. So again, the specific timing of which tests to do is going to be something to discuss with the Illinois Department of Public Health personnel if you come across the situation. In the next slide, we've got if you're dealing with somebody who has been recently vaccinated, now our IgM can have false positives due to the vaccine response, and IgM typically appears 7 to 14 days after a vaccine. PCR can have false positives. If you're doing the PCR testing, you can have false positives due to shedding from the live virus, but the CDC can molecularly type to identify if it is wild versus vaccine type measles. So again, you'll need to confirm what to do specifically with the Department of Public Health. And then somebody who's been previously vaccinated, remember if they have the measles and they were previously vaccinated, it's because they didn't develop antibody. They may not be able to mount the right IgM response. And so if you're clinically suspicious of the measles, you may not be able to use a negative IgM to rule out the disease. PCR will most likely still be positive though. So that's most likely what you're going to be looking for, which is why IDPH particularly is doing more PCR testing. Okay, so let's say you have now discovered that a patient of yours has the measles. Remember, there's no specific antiviral therapy for the measles. Medical care is entirely supportive and to help relieve symptoms and to address the complications such as bacterial superinfections and dehydration. There is vitamin A deficiency is a recognized risk factor for severe measles complications. Hence, children who are hospitalized will be or should receive vitamin A to help with recovery. And then in terms of isolation and case management to help reduce the spread or to reduce the chance the virus infects others, the source case needs to be isolated for 4 days after developing the rash. You want to follow all airborne precautions in the healthcare settings, and healthcare providers should be using the official respirator masks to decrease spread of the virus, to decrease infectivity. So all of this being said, if we go back to our public health approach to the measles, the most important thing that I can say and for you to take away is prevention, prevention, prevention. Vaccination is the best way to prevent the measles. While I do stress that this is an outbreak situation in terms of the number of cases of the measles, I do want to kind of put it in perspective that over 300 million people live in the United States. We have less than 1,000 cases of the measles. This is not meant to be a time to panic. It's really meant to just be a time to be aware that we have the resources to protect our population of patients with using the vaccine as we are supposed to. The CDC has not changed the recommendation for when to vaccinate. It's still supposed to be that you receive your first vaccine between 12 and 15 months and your second vaccine between 4 and 6 years of age. The main thing we need to make sure we do is that we capture all patients, make sure that we have vaccinated all of our patients and not let anybody squeak through the cracks without being vaccinated. Next. So the measles vaccine, the MMR vaccine, it's a subcutaneous injection vaccine. The trade names are either MMR2 or ProQuad. Remember, this is a live attenuated virus vaccine. ProQuad is also a combination with varicella. The maximum age that you can use ProQuad is 12. The MMR vaccine is administered as a 2-dose series of sub-Q injections. Both of these types of MMR vaccines are stored as 2 components, the lyophilized vaccine and the diluent. They need to be reconstituted prior to use. You don't want to expose the vaccine component to light before or after reconstitution. You have a very small window of time to administer the vaccine after reconstitution, so you do want to be smart about when you have your when you draw it up, and of course follow all the package insert requirements for storage, reconstitution, and handling. Like I mentioned, the recommendation from the CDC is really still the same. The first dose given at 12 to 15 months, the second dose given at 4 to 6 years of age. If you are catching somebody up, the spacing between dose 1 and 2 is 4 weeks. It's obviously important to make sure school-age children are fully vaccinated. This is a requirement in the state of Illinois. Just to go back a little bit about the measles vaccine, the measles vaccine, oh no, you don't need to go back on the slide. I'm just talking about the measles vaccine itself. We can go to the next slide actually, and I can talk about it. When we talk about adults, the recommendation from the CDC is that if somebody was born before 1957, the thought is that they were probably naturally exposed to the measles, and so they are considered immune. If somebody was received the vaccine between the vaccine product that was available between 1971 and 1978, the current vaccination recommendation is, well, let's just talk about this here. If no evidence of immunity to the MMR, then you're going to give them 1 dose, and that's in the adult population. If they're born before 1957, you don't need to vaccinate them. And certainly if they have laboratory evidence of immunity or disease, then they are considered immune. On the next slide, this helps us a little bit more. If they were vaccinated before 1968, so between 1960 and 1968, they were given what was called the inactivated measles vaccine. And so the recommendation is to revaccinate those patients with at least 1 dose of the current live attenuated measles vaccine. The next slide tells us what to do with international travel. For infants 6 months through 11 months of age, you can give them 1 dose of the MMR before travel, but then you will still need to revaccinate them with a 2-dose series after age 1. So in my office, we are offering the vaccine to children over 6 months of age who are traveling internationally or to areas of outbreak, but then they do need to be vaccinated again after 12 months of age as per the routine CDC schedule. Next slide. So the contraindications to the measles vaccine would be a severe allergic reaction to a prior dose or vaccine component, a severe immunodeficiency, a family history of altered immunocompetence, and pregnancy. So these would be the reasons to not give the measles vaccine. Precautions, you really need to weigh the benefits or the risks here. Precautions would be a condition in the recipient that might increase the risk for a serious adverse reaction or might cause diagnostic confusion or might compromise the ability of the vaccine to produce immunity. So for example, a moderate or severe acute illness with or without fever, recent receipt of antibody-containing blood products. A person might experience a more severe reaction to the vaccine than would have otherwise been expected. The other precautions or things to think about would be if the patient has thrombocytopenia or thrombocytic purpura, or if they need to have tuberculin skin testing done, then you need to figure out exactly when to do the measles vaccine. The next slide tells us about things that are not contraindications or precautions, so you definitely can vaccinate in these situations. If you have a positive TB test, you can still vaccinate. If you're giving the TB test at the same time, that's perfectly fine. If a mother is breastfeeding, that is perfectly fine to vaccinate them. In the case of pregnancy of the child's mother, so if the mother is pregnant with another child, it is still perfectly fine to vaccinate that child. If the recipient is female of childbearing age, it's perfectly fine to vaccinate them as long as they are not pregnant. If they have an asymptomatic or mildly symptomatic HIV infection, it's actually still okay to vaccinate them. And if they're allergic to eggs, it is still perfectly fine to vaccinate the patient. In this is a map of Illinois showing measles vaccination rates in each county. Though the measles vaccine is required in Illinois schools, the rates are not 100% across the state. If you can zoom in on Cook County, you can see that we have a pretty good vaccination rate here in Cook County, 97 to 98% vaccinated. The next slide tells us the problems with the school districts, though, or individual schools. The school vaccination rate, which is a little different than the overall student vaccination rate, shows that 9.2% of schools are at high risk. So the school vaccination rate is less than 95%. But if you actually hone in or zoom in on Cook County, there are a higher number of schools that are at high risk. 10 to 15% of the schools in Cook County are at high risk because the schools have allowed students to enter without full vaccinations. Religious exemptions are the most common reason for non-vaccination. And in our state of Illinois, that is the only reason. Either religious or medical exemptions are allowed in the state of Illinois. Philosophical exemptions are not allowed in the state of Illinois. And unfortunately, what that also tells us is that schools that are religion-based are more likely to be at high risk in terms of accepting patients who are not vaccinated, increasing the risk of measles spread if there is an outbreak at the school. The most common concern that you may hear from families is whether the MMR vaccine causes autism. It is important to stress that there is so much research out there showing that the MMR vaccine is safe and does not cause autism. Just as background, Andrew Wakefield, who was at that time a physician in the United Kingdom, published a study in the medical journal The Lancet claiming a component of the MMR vaccine led to autism in children who were vaccinated. No other researchers were ever able to reproduce this finding, and in 2010 the article was retracted from The Lancet. Wakefield's conclusion was further undermined by the fact that his research was funded by lawyers looking for evidence against the vaccine industry. He has been permanently barred from practicing medicine in the UK. There are so many well-researched, peer-reviewed articles showing that there is no causal link between the MMR vaccine and autism. It is important to educate yourself. It's obviously important to educate your families about the truth regarding vaccine safety. There can be adverse reactions to vaccines, but they are critical to protect the public from harmful infectious diseases. And I think it's important if you have a patient population that really asks you a lot about this type of literature, it's important to arm yourself with responses in terms of what you know is appropriate and safe and protective, and to give your patients good reading material, good websites to go to actually educate themselves about the vaccine and its safety. Next slide. This kind of goes through a little bit about how public health cases are investigated. Again, it requires reporting of a suspected process is identifying potential contacts or areas of exposure, determining immunity status, identifying who needs post-exposure prophylaxis. The public health department will be monitoring and isolating any other susceptible individuals. Post-exposure prophylaxis includes vaccination within 72 hours of exposure. Like I mentioned, it can be given as young as 6 months of age. It doesn't count as the official MMR vaccine. The individuals would have to be isolated from school and work. Susceptible individuals are monitored for 21 days. Usually, I'm sorry, I'm on the next slide. Large numbers of contacts are typically identified. Unfortunately, the way that the initial case or case one would spread the vaccine is that it's really not uncommon for the confirmed case to have visited many clinics before actually coming across the diagnosis. And without a diagnosis, they don't realize that they need to avoid being in numerous public settings. So obviously there is risk of spread depending upon the susceptibility of the exposed population and the level of contagiousness of the individual. So if there are pockets of unvaccinated or poorly vaccinated individuals, this is how it spreads. So in summary, like I said, prefacing this, measles is on the rise in the United States and globally. 2019 has more cases than 2018 already, and we're not even halfway through the year. I guess we are halfway through the year, or almost halfway through the year. Vaccine hesitancy is the major reason for problem at this point, and it has been identified by the WHO as a significant problem for 2019. Vaccine hesitancy includes complacency on the part of individual patients, complacency on the part of healthcare providers, lack of convenience in terms of vaccine availability, and then lack of confidence that individuals may have in the vaccine itself. Remember that the vaccine is highly effective. Nothing is 100%, but with one vaccine, 93 to 95% of the population does show full immunity. The second dose is given to capture the remaining 5% that didn't respond the first time. That is why we give 2 vaccines to our patients going to school. And then in terms of diagnosing, you need to be aware of what measles is. Think about it in specific situations of unvaccinated patients or recent travel history, or if the illness meets the criteria for the measles. You want to think about how you're going to be actually making the diagnosis, whether it's serum or nasopharyngeal swab, and you want to, of course, call the public health department to help you through all of it and to inform them about the case of measles. This has been a lot of information, and I am happy to answer any questions or respond to any comments.
Okay, so like we do have a question. I'm going to mute you for otherwise there's going to be like, I think, an echo. So, okay, so the first question is, we have a number of patients planning to travel to Mexico and Africa during summer vacation. Is the CDC recommending all international travelers aged between 6 months to 12 months to vaccinate, or only those to the epidemic countries?
Unmuted.
The CDC is recommending vaccination for all 6-month children and older for international travel, period, not just to the areas in Europe and East Asia, simply because you don't know where travelers are coming from. So if you're in international airports, you can have travelers from all over the place. So it's best to vaccinate everybody over 6 months.
Okay, and then another question that we have is, how do you talk to parents who want to claim a religious exemption?
Unmuted.
So the state of Illinois actually has a form that you as a provider are supposed to fill out with the family that claims a religious exemption. The form actually requires the family to document the specific religious tenet that they are quoting as the reason for the exemption. You as a provider should do your best to educate them about the safety of the vaccine, the usefulness of the vaccine, the protection it provides, and to remind them that if they choose to not vaccinate their child, then in the setting of an outbreak or an illness, their child may have to be removed from the school setting for the appropriate number of days while the exposure risk exists. It is, you know, this is just the only thing we can really do at this time based upon law, that religious exemptions are still allowed. But I do my best to just remind them again and again about the safety of the vaccines and the usefulness of the vaccines and the protective nature of them.
Okay, and then another question is, if an 18-month-old has 1 MMR dose, is the patient still at risk?
Unmuted.
So knowing that one vaccine generally protects 93 to 95% of the population, and the second dose leads to 97 to 98% of the population being fully protected, there is still some risk in an 18-month-old. The reason this never was much of an issue in the past was because there weren't endemic cases in the United States. We relied upon herd immunity in general to make sure that everybody was protected. But now that there are increasing numbers of measles illnesses abroad and finding their way here in the United States and then spreading within a higher risk population, if your 18-month-old patient is traveling internationally or is going to be in an area of the United States where there seems to be a higher number of cases now, it is worthwhile having them get their booster dose. As long as it is 4 weeks from the prior dose, it's considered a valid dose. And in the state of Illinois, those 2 doses then would count as that child's official dosing. You don't need to then do another dose at 4 to 6 years of age. A child just needs 2 doses after the age of 12 months, 4 weeks apart.
Okay, and looks like this is the last question so far, but after this, I'm going to go over some stuff, and if more people have questions, then they can continue to enter them. But this question is, child care centers struggle with the issues as some families want to enroll non-vaccinated children. Do you see Illinois changing this law?
Unmuted.
is the question that that DCFS, which licenses the child care settings, is going to require vaccination? Is that the question?
I think so. If she has like any follow-up, but from what I'm reading it as, that's kind of how I'm reading it.
Unmuted.
Licensed childcare providing locations or licensed childcare providers need to follow the DCFS rules, and at this point in time, the rules are set, or the laws are set for school entrance and for children who are in the Vaccine for Children program and who receive public assistance. But private childcare providers aren't required at this time to follow other guidelines. I think that would be a great way to make a change, to require all locations of childcare to follow at least what's required at certain, at the appropriate ages. But I don't have a great answer to that at this point. I think it's a great idea, but I don't have a great way of changing it at this point.
Okay, and looks like we had some more questions come in. So another one is, do you recommend checking measles titers routinely in patients?
Unmuted.
No, the CDC actually doesn't recommend checking titers. It's best to just vaccinate if you don't think that they have the appropriate number of vaccines. It's also less expensive to vaccinate than to check titers.
Unmuted.
Unfortunately, there are people who do not respond to the measles vaccine. And so going back to herd immunity, this is why everybody needs to be vaccinated, so that we don't have spread of the disease in our population. But there are some individuals who, even if you check their measles titer and then you vaccinate them again and you check their titer again, they just do not respond. So the best scenario is just to make sure that everybody has received the vaccines that they're supposed to receive, and then that'll provide some herd immunity to protect those who cannot respond or whose bodies are unable to respond.
Okay. Oh, and Janet Daniels, she responded. She said that DCFS does require at least one dose of MMR on or after the first birthday. So that's probably related to like the child healthcare centers and something code 665. Okay. So the next question is, if the second dose can be given within 4 weeks of the first dose, why do we wait to age 4 to 6 years rather than giving it sooner, e.g. 2 years?
Unmuted.
Some of the decisions about when vaccines are given are also based upon the timing of children throughout the country going to see their doctors. There are requirements for entering kindergarten, there are requirements for entering 6th grade, 9th grade. And so some of the rationale for giving vaccines was based upon that it was a time that children would be coming in to see their doctor or their healthcare provider. And again, because measles was essentially eradicated in the United States, this was not an issue. With this situation, this may be something that the CDC has to reevaluate. But good question, good thought.
Okay, and then I'm assuming this question then, so the recommendation for current timeline, if a 12-month-old already has one dose, do we vaccinate at least 4 weeks after, or do we wait until 4 years old?
Unmuted.
So if there is not exposure risk specifically, so if they're not traveling, if you're not in a place where there is specific exposure risk, then the recommendation is to stay the course. 12 to 15 months and 4 to 6 years. If you're concerned that your patient is going to be traveling, or the parents are requesting it because they're concerned about it, or you're living in places where there's a higher incidence, then you could do it 4 weeks later.
Okay, and I think Alicia Fortner just has another quick comment, I think, for everyone about DCFS. that you can see the health requirements for children section in the under the administrative code 407.310A4. Okay, so right now it does look like those are all of the questions that I have. But as I said before, if you do have more, enter them in. I'm just going to go over some quick closing up the webinar general announcements. So this is our page. It just shows the upcoming webinars that we have. We have 2 more next week. The first one is going to be on immunizations using social media for outreach, and that will be from 12 to 1 as usual. All of our webinars are always from 12 to 1 p.m. And then you can register at the link below. And then our second one next week is going to be on perspectives on vaccine hesitancy. And we're pretty excited about this one because it's going to be hosted by Dr. Gary S. Marshall, which is the author of the Vaccine Handbook, which is that small little purple book. I think a lot of us probably have seen it or, have owned it at one point. So definitely, register that if you're kind of looking kind of for ways about how to talk to parents and everything on vaccine hesitancy, and you can register at that link below. We also routinely will send out like emails to everybody about registration. So what next? Everyone will receive a copy of the PowerPoint slides. They're going to be in PDF format, a link to complete the evaluation, a link to recording of the webinar, all by the end of business day tomorrow. And in terms of the evaluation, everyone has to complete that by July 4th. After that date, we will be closing the evaluation, and you will not be allowed to fill it out or receive a certificate of completion and or continuing education credit. And then everyone who does complete their evaluation should be receiving their certificate on or before July 18th, 2019. And then, looks like I did have another question. So it's if in Illinois, if a second dose is given prior to 4 years of age, does it still count? Like, I think they mean like in terms of like school requirements and everything.
Yes.
Unmuted.
Yes, it does still count.
Okay, great. And then the other question, this is just a general question about can we circulate, present, and share the slides? Yeah, of course, like definitely, if like anybody in your clinic wasn't able to attend, like feel free to like share the slides with them. They're just going to be in PDF format. You can print those out, like give them, pass them out, give them around. This webinar, we will be posting it on our YouTube page also. So for those who missed it and they kind of just, want to watch it live and get like more of the comments that aren't going to be quite in the presentation, everyone can definitely do that. In terms of will the questions be on the PDF, they won't, but we can definitely send those over to you if you want. Just like give us an email and we can go ahead and do that. And then, somebody just said that school law states that the second dose has to be received after age 4. So I don't know, Anita, do you have a comment on that?
Unmuted.
I don't have the school code in front of me, and we can certainly follow that up with everybody. In fact, that's what we should do, is follow it up specifically. But as far as I understand it, not for the measles. That's the case with the tetanus booster and the polio booster, but not with the measles or with the varicella vaccine. But I will absolutely confirm that because I don't want to lead anybody astray. And we will email every participant when we email the PowerPoint slides or the PDF of these slides. We will confirm that for you.
Okay, so I did have Janet Daniels, who works at IDPH, who says that Dr. Chandra, you are correct that even if they receive it before 4 years of age, it does count. But definitely we'll, look that up again, and then we'll show everybody just to, if anybody is feeling a little bit uncertain, just to kind of have, a little sense of feeling of safety or anything for that. So I think that this webinar then concludes. Thank you so much to everybody who participated today, and I definitely really love that everybody had so many questions and like kind of discussions that were going on today. I think it was a really kind of good display about like people who were sharing information on live time, even if I was the one reading it all out loud. So thank you to everybody who participated. And thank you so much to Dr. Anita Chandra-Puri. That was a excellent presentation. So yeah, feel free to sign up for any of their future webinars, and hopefully we'll see you all again in the future virtually. Okay, bye.